antenatal care setting and deserve our attention. So I'm very happy today to have, I think, a great list of speakers. Unfortunately, we've been working for the last several days to try to get connectivity for Nellie Mugo, who was supposed to be our first presenter, and she's done a great job developing slides and was planning to be on, and we've been working down to the wire, but it looks like Nellie's not going to be able to join us this morning, so I will be presenting her slides. But again, she did all the work on this, and she's a professor at the Kenya Medical Research Institute and at the University of Washington Department of Global Health, and also works for the Partners in Health Research and Development. Also on the agenda today, we're very lucky to have Lynn Moffinson, who many of you I'm sure know. She's been working in the area of mother-to-child transmission for at least the last 30 years, and she's currently working at the Elizabeth Glaser Pediatric AIDS Foundation, and she has done a lot of work on the safety of drugs used for pre-exposure prophylaxis in pregnancy and breastfeeding for WHO, and we'll be sharing her information. And then we have two representatives of the community, because obviously a very important consideration is whether this is something that the community is interested in, and if so, how we can facilitate availability of pre-exposure prophylaxis if indeed it's deemed an appropriate intervention. And we have Teresa Njoki from the Athena Network, who works on community engagement and advocacy and is on the steering committee of many international community groups of representing women living with HIV, and Angelina Namibia, who's an associate at the Salamander Trust working on 4M Peer Mentoring Project for women living with HIV, and is again a community representative on boards, many boards, including the WHO Clinical Guidelines Development Group. So with no further ado, I will run through Nellie's slides. I'm sure not nearly as articulately as she would do, but I'll go through her slides. Then we'll have Lynn's talk on safety, and then we will hear the community perspective. And then after we've gone through all of the talks, we should have at least a half an hour for question and answer and discussion. So does anybody have any issues before we get started? Okay, so can I control the slides myself, or?
Yes, Heather, just click the make as presenter, the top button, the button on top of the presentation. Just click that so that.
Oh, okay, got it. Okay, and then I can just use my arrow key or something. Okay, great. So this is an outline for the talk, talking about the efficacy of PrEP. What do we know? What do we know about risks during pregnancy and breastfeeding and seroconversion? What information do we have so far about where PrEP might be desired for use during preconception and pregnancy? Because again, I think a big area is the issue of serodifferent couples who desire conception without the risk of seroconversion, who might be eligible, and when is PrEP indicated in pregnancy. So the data thus far, again, I think most people are familiar with the data from randomized trials. The Partners PrEP study that was done in Kenya and Uganda had almost 5,000 serodiscordant couples, including both women who were living with HIV and women who were not living with HIV but whose partners were, and that demonstrated efficacy of 75% and 67% for Truvada and for tenofovir. The TDF2 trial in Botswana, again, included heterosexual couples, demonstrated 62% efficacy. And you can see other studies here also looking at efficacy in various groups. Of course, one of the issues has been that some of the trials have not shown efficacy in women, for instance, the VOICE trial and the PrEP trial, and that was felt to be related to poor adherence. And you see here where adherence studies have been done using drug levels, that not surprisingly, as the adherence increase, so does the prevention of HIV effect. So again, one of the key issues will be making sure that if these drugs are available and that they will actually be used. Again, one of the issues with VOICE and FemPrep is that these were randomized controlled trials with placebos, and women didn't know if they were getting active drug or not. So there was perhaps a bit of an issue with adherence related to not really knowing if it would work. So looking at open label studies, again, the study in the UK, the PROUD study, 86% effectiveness. IPREGAY study, again, on-demand PrEP among MSM in France and Canada, 86%. And open label demonstration projects in the U.S., again, have shown much better adherence in open label studies than in some of the clinical trials. In the Partners demonstration project, which was after the end of the study and the efficacy was shown, among the serodiscordant couples in Kenya and Uganda, only 4 infections occurred among those continuing, and 83 would have been expected, and none of the 4 seroconverters were actually taking PrEP at the time that they became HIV infected. So again, 95% reduction in incidence, and this was just presented at IAS recently. Again, continued high use even with continuing the trial, and also instigation of ART in the infected member of the couple. And again, I think it's important as we talk about the issues with pre-exposure prophylaxis to think about the fact that this is not necessarily a lifetime thing, but as Nellie likes to say, sort of for seasons of risk. And in many cases, if you can get young women over a very high-risk time in their life until they get into a situation where they're in a monogamous relationship with someone who's willing to be tested and is known to be negative, that you don't have to continue PrEP forever. And also, if you identify a serodiscordant couple and can get the HIV infected person onto treatment and get their viral load suppressed, the PrEP is indicated for the first 6 months or so while they're suppressing their viral load. So again, we're not talking about lifetime PrEP like we would be with ART. Again, I think just emphasizing that in the demonstration projects there was higher adherence often and high effectiveness. Again, this is a summary. I think this is a very nice slide of the clinical trials data on a number of different options, but today we're talking about the pre-exposure, and as I've mentioned, if it's taken, it's highly effective. What about the risk of acquisition during pregnancy and lactation? And this slide actually is from Lynn. Thank you very much, Lynn, from her WHO summary, looking at the rate of HIV acquisition during pregnancy and lactation in many parts of Africa, suggesting that the risk is quite high, up to 4.7 per 100 person years among pregnant women in these populations, and 2.9 during breastfeeding. So again, depending on the location and the population, certainly above the risk of the 3% threshold in the current WHO guidelines. And many of these are recent studies, although I will point out obviously that many of these also antedate the broader availability of ART for infected patients, so that the risk may not be quite as high in current studies, but again, in some areas is still high. what about the risk of transmission? And I think there's been discussion about whether the risk of transmission is higher with incident infection during pregnancy or breastfeeding because you have the high viral load and lack of maternal antibodies, which may increase the risk of transmission. Not all studies have been shown an increased risk, but what I would point out here is that on this slide you see the risk is anywhere from 10 to 30%, that the fact is that if we know somebody is infected, say when they enter pregnancy or when they get tested during pregnancy and get put on treatment, we know that we can reduce the risk of transmission to under 5% and generally well under 2% with early initiation of therapy. So I think the big issue here is that many places are still not consistently doing follow-up testing in pregnant women or lactating women to detect these infections. So the risk is going to remain high because the women aren't recognized as having infection and aren't being treated. You see the summary risk is 18%, which again is still quite above the risk of 2% or so with early initiation of therapy. Likewise, breastfeeding, again, some of the early studies showed very high risk of infection with seroconversion during breastfeeding. And again, even now, the risk is high overall of around 26%, which again is a lot of this risk could be mitigated if these were recognized, but the infections are often not recognized. So the WHO guidelines that came out in the fall included recommendations for oral PrEP containing tenofovir, not specifying tenofovir, emtricitabine, tenofovir, lamivudine, leaving that open, should be offered as an additional prevention choice for people at substantial risk of HIV infection as part of combination prevention approaches, including condoms, including obviously referring men who are uninfected for voluntary medical male circumcision if appropriate. And their definition of substantial risk was defined as an incidence greater than 3 per 100 person years in the absence of PrEP. And when are pregnant women at substantial risk? As we discussed, it's going to vary by geography and population. There are many, certainly many areas in southern and eastern Africa in high endemic populations where the risk for a woman will be higher than 3 per 100 person years. HIV serodiscordant couples in which the infected person is not on treatment obviously have a high risk of transmission, especially obviously without consistent condom use, and the fact that a woman's pregnant suggests at least some unprotected sex to achieve pregnancy. And then in concentrated epidemics, there again may still be areas with a high prevalence and thus a high incidence, including female sex workers, women living in fishing communities, partners of truck drivers, things like that. And obviously people would have to assess the risk in their given area. Again, in the Partners Demonstration Project, when women were given the option to continue PrEP if they became pregnant, 88% of the women chose to use PrEP, and they're being followed for more data on birth outcomes. When we think about use of a pre-exposure prophylaxis, we have to be aware that there's at least a 40% risk or 40% of pregnancies are unplanned and may occur while people are on treatment. And this rate varies, but is anywhere from 35 to 40% in Africa. So that if we're talking about fairly widespread use of pre-exposure prophylaxis in high-risk women who are not pregnant, we have to be aware of what the data shows as far as safety if they do become pregnant. Obviously, breastfeeding is very important and preserves infant health, prevents early childhood mortality, but may increase the risk of HIV acquisition in women for many reasons. Physiologic changes in the vagina may lead to flora changes that enhance risk, hypoestrogenemia during breastfeeding. There may be a risk of their partners having additional partners during the breastfeeding period. And again, there's a high risk of transmission, especially if this infection is unrecognized. So again, women who are pregnant and breastfeeding are in the medical system and represent opportunities to provide additional options for prevention of HIV infection to try to lead to an AIDS-free generation. The other issue is that, again, there are known serodiscordant couples in which the woman is negative and the partner is positive, and they would like to conceive, and they would like to do that, but with minimizing their risk of infection. And this is a study by Nellie and her group, and discusses the fact that there are fertility intentions and risk perceptions among couples, and that they would like to minimize their risks of infection. These are some quotes. An HIV positive woman, my husband would refuse and say, if it's infecting me, just infect me, I accept it without protection, again, for not using condoms. It can bring conflict into a house when a man wants a child and he knows there's a risk, and he's positive and she's negative. So again, very strong interests. Again, there's no reason to think women living with HIV are any different than any woman who would like to have a child, or a woman living with a positive partner obviously would like to have a child and minimize her risk. So at this point, I think you can see there's a lot of need for enhanced methods for HIV protection during pregnancy and breastfeeding. The products must be safe, both periconceptionally because of the risk of unintended or intended pregnancies on PrEP. There's also the issue of what continuing PrEP, what effects it could have on pregnancy and during breastfeeding. But again, we need to look at these, and Lynn is going to lead us through some of those discussions. It's always a balance between risks and benefits in determining whether to include pregnant women as a population. I think we see this in so many settings where pregnant women often don't have access to the state-of-the-art therapy for a medical condition because people are afraid to study drugs in pregnancy or to give drugs in pregnancy when they fail to consider that the risks of not treating a woman who's pregnant with the standard therapy may actually be higher for her. And again, not thinking just of HIV, but many medical conditions. I think that as we look at this, again, we've improved the antenatal care programs in many countries, and we've introduced PMT-CT in these settings, so we have these drugs available, and that there's a big missed opportunity when we think about the women at risk that may benefit from this. Again, we have to take into consideration the community considerations, and we'll be hearing about those shortly. Again, we have to make sure that if this is an intervention that we want to use, that we put in methods to help with adherence so that the drugs are actually working and so that infection doesn't develop and resistance doesn't develop. Again, there's no biological reason to think that these drugs don't work in women. It really seems to be an adherence issue. So again, we need products that are safe. We'll talk about the safety. Fertility Desires is global, obviously, and PrEP provides a cost-effective option for implementation of safer conception options for women at risk, women and men at risk for HIV infection. We know that pregnancy is a time of increased HIV risk, and that PrEP is potentially an important tool for elimination of mother-to-child transmission. So at this point, I will stop being the presenter and turn it over to Lynn and recognize the people that Nellie has listed, people in groups for slides, and also Lynn's contribution to many of the slides in this set. And let's now hear about the safety of PrEP in pregnancy. Take it away, Lynn.
Okay. Can everybody hear me?
Yes, we can.
Okay. Okay. So here we go. So I'm going to talk about three levels of evidence. One is in HIV-infected women. One is in HIV-uninfected women but who have hepatitis B monotherapy. And then the last group of evidence comes from PrEP. Let's see here. So I want to start by briefly describing the results of past reviews. So there have been 2 systematic reviews of antiviral therapy in pregnant women with chronic hepatitis B infection. Brown included 26 studies. WHO did a systematic review that included 35 studies. However, of these, only 3, 1 randomized trial, 2 observational, with 141 women involved tenofovir. No specific problems were noted, but you'll see that WHO notes that the quality of evidence was low. However, despite this low level of evidence, tenofovir use in the 3rd trimester of pregnancy to reduce perinatal transmission of hepatitis B is recommended or allowed by both the U.S. Society for Maternal Fetal Medicine, the European Association for the Study of Liver, the UK National Guidelines, and the 2015 WHO Hepatitis B Guidelines. So several reviews have evaluated tenofovir in HIV-infected pregnant women. There was a systematic review by Wang that identified 13 relevant studies, but only 4 of these studies had a comparison group. Earhart reviewed limited data on tenofovir in breastfeeding, finding only 2 studies on breast milk. And a systematic review done by WHO last year included 9 studies, and a recent update of that for this last year's guidelines update found 2 additional studies, and there was considerable overlap between the reviews and the studies. So the prior 6 reviews represent 23 unique papers. So I did this review at WHO's request. I did a PubMed search and reviewed abstracts, and also communicated with Gilead and identified 242 citations after review 54 papers that involved 28 comparative studies. This includes the 3 reviews. So there were 23 papers on tenofovir treatment in infected women, 20 of which were comparative. 6 pharmacokinetic studies of tenofovir treatment in HIV-infected women, and 8 studies of single-dose tenofovir. 4 case reports, which I'll talk briefly about at the end. 9 papers on tenofovir with hepatitis B monoinfection, 6 of which were comparative. And then finally 4 papers on tenofovir PrEP, 2 were comparative trials. So this results in 28 papers that had a comparison group for the primary review, and the exclusions are shown on this slide. But I also want to point out that outcomes were very inconsistently reported between the studies, and you can see there's a varying number of papers reporting on the different outcomes that I looked at, ranging from only 2 papers to as many as 12. So before I start, I want to give several caveats related to the relevance for PrEP. So the HIV studies all reflect 3 drug regimens as opposed to 1 or 2 drug PrEP. Most start in the 2nd or 3rd trimester. Only 5% of all of these studies included women receiving tenofovir at conception. And also HIV positive women have worse pregnancy outcomes than uninfected women, even in the current treatment era. So it might not be comparable to use in the uninfected women, and may give us a, quote, worst case scenario. The hepatitis B studies enrolled women with high hepatitis B DNA load, and they all primarily start in the 3rd trimester. In this group of studies, less than 1% received tenofovir from conception. And the PrEP comparative studies are the most relevant, of course, but they all stopped PrEP by 1 to 2 months gestation. So women were in the PrEP studies, they were not pregnant. If they became pregnant, they were supposed to stop PrEP. Also, in at least the VOICE study, adherence to PrEP was low, so whether the results from that study reflect exposure is unclear. So I want to start by briefly reviewing the pharmacokinetic studies to give us some background as to what the exposure looks like. So this slide shows you pharmacokinetic studies of tenofovir treatment in pregnancy in HIV-infected women. Tenofovir has a lower AUC by 20 to 33%, lower trough levels by 18 to 37% during pregnancy compared to postpartum. However, it's felt that standard doses appear to be adequate for most women except those who are moderately obese, and drug adjustment is not recommended during pregnancy. So looking at amniotic fluid and cord blood, in the two studies that evaluated it, tenofovir levels in amniotic fluid were actually higher than in maternal plasma, suggesting that tenofovir concentrates in amniotic fluid, and this has been seen for other drugs such as 3-TC. Cord blood studies demonstrate excellent transplacental passage with levels near to or higher than maternal levels. So the infant is definitely exposed to tenofovir in utero when a woman is taking it. So in terms of breast milk, it's first important to recognize that tenofovir itself, the active drug, has very poor bioavailability, and therefore it's administered as tenofovir dispropyl fumarate, a water-soluble diester, which that is goes easily across epithelial membranes, and when it gets into the blood, it's rapidly converted into the active drug in blood. So what's in the blood is this low bioavailability active drug, tenofovir, and one would expect that one would see minimal penetration across the breast milk epithelial barrier into the breast milk, and indeed from these 4 studies, that's exactly what was seen, with very low levels in the breast milk and levels that were either unmeasurable in the infant or extremely low, with infants being exposed to 0.2 to 0.03 to 0.01% of what they would get if they were getting a dose. So there's very minimal penetration into the breast milk. So moving to the results of the comparative studies on pregnancy and infant outcomes, I'm going to present you a series of slides, but because the HIV-infected population is very different, as you'll see, than the hepatitis B or PrEP populations, for each one of these outcomes, I'm first going to review outcomes for HIV, and then I'll review outcomes for hepatitis B and PrEP. And I'm going to keep the y-axis parameters the same on all the graphs, and that way you'll be able to see the differences between HIV and non-HIV populations in terms of outcomes. So this slide shows pregnancy incidence in HIV-infected women on tenofovir treatment in blue and non-tenofovir treatment in red, and also the studies in HIV-uninfected women from 2 PrEP studies, with tenofovir PrEP in blue, tenofovir FTC in light blue, and placebo in orange. And pregnancy rates, you can see, were lower among HIV-infected than uninfected women, but as you can see from the p-values, they did not differ by regimen. And as I go through these slides, I'm not going to go into each detail because, as you'll see, most of the p-values in all of these studies were negative. And I believe the slides will be available after the presentation. So this looks at stillbirth. In terms of HIV-infected women, it was evaluated in 2 studies. Again, tenofovir is in blue, non-tenofovir treatment in red, and where there's a comparison, AZT single-dose nevirapine is in green. And you can see that there is no significant difference between any of the regimens in either study in terms of stillbirth. So the ZASH study looked at tenofovir and non-tenofovir regimens and also divided it up by the time that the treatment was started. So she compared preconception, tenofovir, non-tenofovir, and starting tenofovir during pregnancy, tenofovir, non-tenofovir. And again, you can see no difference in terms of stillbirth between tenofovir and non-tenofovir treatment started at either time. Pregnancy loss, spontaneous abortion, and stillbirth were looked at in the PrEP studies in women who did get pregnant while they were receiving PrEP. There was no significant difference between tenofovir in the dark blue, tenofovir FTCT, in light blue, and the comparison arm in orange. The numbers of pregnancies here were relatively small. There were 312 in the tenofovir group and 196 in the placebo group. And here we can look at the hepatitis B monotherapy studies, and you can see what I'm talking about here. This is the same y-axis. You can see that the rates of stillbirth and spontaneous abortion are significantly lower here, very low rates, and again, no difference between arms comparing tenofovir, 3TC, or no drug. So this slide shows preterm delivery at less than 37 weeks from the HIV studies. Preterm rates ranged from 9% in the smallest study with 251 women receiving tenofovir treatment to a more consistent 18 to 21% in the 3 larger studies. And you can see there was no significant difference between regimens. And in the PROMISE study, shown the 3rd study there, both tenofovir in blue and AZT treatment in red had non-significantly higher preterm rates than AZT single-dose nevirapine, shown in green, but the rates between the tenofovir treatment and the zidovudine treatment were similar. So 2 studies compared preterm rates in HIV-infected women starting tenofovir either preconception or during pregnancy. You can see in the ZASH study there's not a significant difference between tenofovir and non-tenofovir regimens, although the preterm rate for both appears higher in women starting preconception than during pregnancy. The second study didn't have a comparison group. It looked at tenofovir preconception versus during pregnancy, and you can see they did not find a difference in preterm delivery rate by the timing of tenofovir initiation. Now, 2 studies evaluated very preterm delivery. This is less than 34 weeks. In the PROMISE study, tenofovir treatment had a significantly higher very preterm rate than AZT treatment, shown in red. Remember, for the regular preterm, there was not a significant difference. However, if you compare the tenofovir treatment in blue to AZT single-dose nevirapine in green, that was not significantly different. And in contrast to the PROMISE study, the ZASH study found no significant difference in very preterm delivery rates between tenofovir and non-tenofovir treatment. So turning now to the hepatitis B and PrEP studies, where tenofovir was given either as a single drug or a dual drug to HIV-uninfected women, you'll note that the rates of preterm delivery are much lower than in the HIV-positive women that we just looked at. And again, there's no significant differences between the tenofovir and comparison groups, the comparison being 3TC in green or no drug and placebo in orange in any of these 5 studies, including the PAN study, which was just published in the New England Journal just a couple of weeks ago. For low birth weight, all but 1 study showed no difference between tenofovir and non-tenofovir treatment. Now, this is again looking at HIV-infected women receiving treatment. In 1 study, the PROMISE study, higher rates of low birth weight were seen with both tenofovir treatment in blue as well as AZT treatment in red compared to AZT single-dose nevirapine in green. But the rates were similar between tenofovir treatment and AZT treatment. So this was not a tenofovir effect, it was more of a 3-drug effect. 1 study compared the timing of tenofovir initiation and didn't find a difference in low birth weight rates between starting preconception versus starting during pregnancy. These are all HIV-infected women receiving tenofovir treatment. Only 1 study, again the PROMISE study, looked at very low birth weight, and while tenofovir treatment had the highest rate, 2%, it was not statistically significantly different than non-tenofovir treatment or AZT single-dose nevirapine, and you can see the p-values on the slide. Turning to the hepatitis B studies, again, you can see there's a much lower rate of low birth weight than in the HIV-infected women that we looked at previously. There's no difference in low birth weight between tenofovir from the comparison groups of 3TC or no drugs in any of these three studies. Small for gestational age in HIV-infected women on treatment was evaluated in 2 studies. Again, you can see from the p-values no significant difference between tenofovir and non-tenofovir treatment or AZT single-dose nevirapine. Moving to birth defects, we have 4 studies in HIV-infected women involving over 3,500 tenofovir first trimester exposures, finding no difference in birth defects between tenofovir and non-tenofovir treatment, with an overall rate of 3.5%, which is similar to the general HIV-uninfected population. Similarly, if we look at the HIV-uninfected women with either hepatitis B or in the PrEP studies, that no significant differences were observed between the tenofovir in blue and any of the comparison regimens ranging from 3TC placebo. Now, neonatal death was reported in only 2 studies in HIV-infected women receiving treatment. In one study, again the PROMISE study, tenofovir treatment in blue had a significantly higher rate of neonatal death than AZT triple drug regimen in red. However, the tenofovir in blue was not significantly different than AZT single-dose nevirapine in green. So rather than tenofovir appearing to have an elevated rate, it appears that the AZT treatment has a lower rate than either group. Most of these deaths were in very preterm infants, which, as you can remember in a couple of slides ago, in the PROMISE study was found to be elevated with tenofovir treatment. And I think this is really a reflection of the way the study was conducted. The tenofovir comparison was limited to the second half of the study, which enrolled only about 1/3 of the participants. And there were differences in the AZT group in terms of the number of deaths in the first part, which didn't compare to tenofovir, versus the second part, which did. So I think there's something a little bit funky about that data. And you can see from the Gibbs study in Africa, there was not a significant difference in neonatal death. This slide looks at the hepatitis B and PrEP studies. There were 5 studies, no significant differences seen in these studies in neonatal death between tenofovir and the no-drug placebo arms in orange. Now moving on to talk a little bit about anthropomorphic parameters, and this slide shows birth weight for age z-scores in 4 studies in HIV-infected mothers receiving treatment. And you can see that there was no significant differences between tenofovir and non-tenofovir treatment. All of the kids have a negative z-score pretty much, but not difference between what their mothers received during pregnancy. And this slide looks at birth length and head circumference z-score in 3 studies. And the statistically significant difference in the Gibbs study shows that the tenofovir treatment arm in blue actually has a better z-score, closer to 0, for length than the non-tenofovir treatment arms, and no other differences were observed. And this slide looks at weight for age z-scores at age 6 to 12 months in 3 studies. No significant differences between tenofovir and non-tenofovir treatment. And this slide looks at length and head circumference z-score at age 9 to 12 months. And one study, the Cyberry study, found that tenofovir exposed infants had somewhat lower z-scores than non-tenofovir exposed infants, although in this exact same study, the parameters at birth were the same and exposure stopped at birth. So this is a little peculiar and not explainable to me anyway. The other study showed no significant differences. And this is a busy slide, but there's just one main messages. This is a variety of other studies that looked at different variables for growth, so I couldn't plot them to make it clearer. Only one study, the little Deneman study there shown, found a significant difference in growth with tenofovir exposure. And they found that growth was, there was a significantly lower birth weight for age z-score and 6-month weight, height, and age z-score with tenofovir treatment versus non-tenofovir treatment, although there was no difference in severe growth impairment. But the main point with this study is there were only 9 kids that had tenofovir treatment exposure, so I don't think you can draw anything from this really. Altogether, these represent 219 tenofovir exposures and over 3,000 non-tenofovir exposures, and other than that one study, no difference in growth at birth or at age 6 to 12 months were found. So this looks at bone and bone markers. 7 studies looked at these. Most of these studies have found no effect of tenofovir compared to non-tenofovir treatment. In one non-randomized study, the Cyberry study there, the 4th row, they found a decreased bone mineral density with tenofovir exposure versus non-tenofovir treatment. However, in a randomized trial, the PROMISE trial, the next row down there, while neonatal bone mineral density was lower with triple treatment than AZT single-dose nevirapine, it was not significantly different between tenofovir and non-tenofovir treatment. And I'll show you that slide here. Oh, I thought I was going to show you that slide, but this is a different slide. Okay. This is data from a study by Jail, and she looked at fetal long bone growth by ultrasound in women who were receiving tenofovir treatment with different durations, either greater than 25 weeks, 10 to 24 weeks, or less than 10 weeks. And she compared long bone growth. And you can see from the graph that there was no significant difference by duration of tenofovir exposure in fetal long bone growth. This is the Cyberry PROMISE study that was shown at Croy. And so this is looking at bone mineral density, and in black you see AZT single-dose nevirapine, in blue you see AZT treatment with Kaletra, and in red you see tenofovir-based treatment with Kaletra. And while there is a significant difference between the AZT treatment and the tenofovir treatment compared to AZT single-dose nevirapine, there is not a significant difference between the AZT treatment and the tenofovir treatment in this randomized study. So only a few studies really evaluated maternal adverse events. These are data on maternal adverse events from the PROMISE trial, a randomized trial. No significant differences overall were seen between tenofovir and non-tenofovir treatment or AZT single-dose nevirapine. When they looked specifically at grade 2 or higher chemistry was seen both with tenofovir and AZT treatment compared to AZT single-dose nevirapine, but there was not a significant difference between the 2 treatment regimens. And this is 4 different hepatitis B studies. So now we're talking about HIV-uninfected women with hepatitis B mono studies, and they're looking at maternal adverse events outside of hepatitis flares. I didn't include liver function tests here. In one study, there was a slight increase in creatinine and a decrease in GFR between baseline and delivery, although all of these values remained within normal limits. In one study, there was a higher frequency of grade 1 or 2 creatinine kinase in the tenofovir group, but no differences in grade 3 or 4 events, and I didn't really think there was anything striking found here. This study looked at bone mineral density in breastfeeding women receiving tenofovir treatment compared to AZT single-dose nevirapine. And you can see that there's a decrease in hip and spine. The hip is in green, the spine is in red, between 2 and 9 months in breastfeeding women. And this is normal. If you're breastfeeding, your bone mineral density goes down while you're breastfeeding, and this is it reverses after cessation of breastfeeding. When they compared T-scores between women on AZT single-dose nevirapine, option A, to those on tenofovir treatment, option B, there was no significant difference in hip or spine T-score with non-significant p-values, as you can see here. Now, in contrast, just presented at the pediatric workshop a couple of weeks ago, these are data from postpartum PROMISE, in which women with CD4 count greater than 350 were randomized to maternal tenofovir treatment compared to, now this is the postpartum piece, so either the mothers got tenofovir treatment or the babies got infant nevirapine. So you can compare maternal triple drug treatment to no maternal treatment at all, since the infants were getting nevirapine. And you can see for lumbar spine and for hip, when you compare the tenofovir group with, in black with the no treatment group in blue, there was a 3.2% decline in spine, a 2.3% decline in hip, bone mineral density between 1 and 74 weeks postpartum. We don't have data on what happens after breastfeeding ceases to see whether this comes back up. The case reports, I think, are completely non-useful. They provide 4 reports on 6 patients reporting on birth defects that are completely different, not found in the larger pregnancy registry. And the 2012 report on fetal growth blunting had a fetus that was only exposed to tenofovir for the last 2 weeks of pregnancy. So I don't think that these studies are useful in terms of trying to look at safety issues. This slide shows the clinicaltrials.gov listing of trials that are still ongoing. Most of them are hepatitis B in pregnancy in relatively small numbers. One study from China is reportedly over, but no results are available, and others are still in process. So in summary, we know there is significant in utero exposure because tenofovir is found in high levels in amniotic fluid and cord blood. And while the safety data I think that I've reviewed with you are very reassuring, most are not from the population of interest, HIV-uninfected women. Most studies come from HIV-infected women on treatment who already have higher adverse pregnancy outcomes than in uninfected women. And this may be exacerbated by triple drug regimens, so I think that we can view that as a, quote, worst case scenario. And in HIV-infected women, tenofovir treatment appears generally similar to other treatment regimens in terms of maternal pregnancy growth outcomes, and there's limited exposure during breastfeeding. There does appear to be a potential for decrease in maternal bone mineral density when receiving tenofovir, but this was only evaluated in HIV-infected women. And I do want to point out that when you look at bone mineral density in the PrEP studies in MSM, you do see a decrease in bone mineral density with tenofovir use. It stabilizes over time. After a year, it doesn't appear to go down anymore, and it appears to reverse when it's stopped. Studies in HIV-uninfected women have much lower numbers. Most have adverse event rates significantly lower than the infected population, with no obvious differences between tenofovir and the control regimens. So I conclude that the benefits of PrEP in women who are at high risk of HIV acquisition appear to outweigh any risks observed to date. Now, that doesn't mean that there's not potential risks. There's always potential risks when someone's taking a drug. But if you have a high risk of HIV acquisition, these risks are not high enough to outweigh the ability to prevent it. And then finally, as PrEP in women of childbearing age is being implemented, it's going to be important to continue surveillance of maternal pregnancy and infant outcomes to confirm the safety that the reviews to date suggest. And I think that's it.
Great. Thank you so much, Lynn, for this very thorough review of the data so far. Obviously, I think we have a lot of data, but always need more. At this point, I'll turn it over to Teresa and Angelina, whom I introduced before, let us hear about the community perspective on all of this, to see where we are.
Just to quickly interrupt, Heather, just reminder, I'm just conscious of the time to keep the presentation between 20 to 25 minutes. And also for those who just joined in, I'd appreciate it if you could introduce yourselves via chat with your name, organization, and country. Thank you.
Thanks. Teresia and Angelina?
Thank you. Teresa,
thank you so much. Hello, everyone. My name is Teresia, and Angelina will also be presenting on the same slide. So I'll talk briefly about a consultation we did. I'm from the Athena Network and also from the International Community of Women Living with HIV. Also having worked as a NAVAC fellow, working on PrEP and perspective of the community, and also making sure that communities and women in 0 different couples understand PrEP in Kenya. So when we were requested to present in this webinar, one of the things we asked ourselves is whether our communities really understand the issue of PrEP and pregnancy. And so what we did is to have a consultation, an online consultation through different listserv, the Athena Network and ICW Network listserv. So we were able to ask the questions that we thought are important and can help us bring out key messages, but also with other networks, for example, the global project of sex work. So what we did is ask these questions, and that's what I'm going to present, and I'll give the key messages and some concerns, and Angelina will talk about some of the opportunities that were presented. So as I said, we did this consultation seeking information from young women on their perspective about PrEP. And we understand that there is not much information about PrEP and negative women, and that has been brought out by Lynn in her presentation. Also, the Global Network of Sex Workers did a consultation globally in 10 countries and in 5 regions, and that report is going to be out very soon, but some of the preliminaries are included in this presentation. Just to mention also, the International Community of Women Living with HIV will be doing a research to be able to document knowledge, perception, and preferences of young women on PrEP in Kenya. And Athena Network also will be implementing a project on Lead Evidence Advocate Research Network that will give us more qualitative data from the community so that we understand how we can implement PrEP and how others can use PrEP when it is available. So from the presentation, it is clear that PrEP is very significant in terms of prevention, but also we also understand that there needs to be knowledge. People need to know, women need to have knowledge on the risks of using PrEP, and also women need to understand better, for example, what is the long-term risk of using antiretroviral drugs. And Truvada is one of the drugs that is being used for PrEP, and that is one of the data that is not available. But as we champion PrEP and say yes, it should be available, yes, it is a very significant prevention tool, what are we doing to make sure that also the community have this information and knowledge? And I don't want to talk more about PrEP without pointing to the fact that PrEP in itself is not available, as we might say, because a woman would not walk in the clinic, for example, somewhere in Kenya and get PrEP. And so when you look to the reality between the West versus Sub-Saharan Africa, we see that PrEP is not usually available for women, and you wouldn't go there and say, I want to prevent HIV because I want to get pregnant, yet it is in small places in demonstration site. So first of all, can we have a deep conversation of making PrEP available for all women? The other thing we want to talk about is the issue of young women and accessing PrEP, but also how can we have these services being integrated to make sure that they also access regular testing and also issues of other HIV safety. For example, what happened to the structural way of HIV prevention? Why are we not investing in such programs to make sure that women have a comprehensive HIV prevention strategy, including women who are pregnant? So it is true we don't have a lot of data in terms of safety and PrEP, but also the community is asking what will be the ethics around encouraging women to take medication that probably could reduce their treatment options in the future. We know that there is probability and most probability for women at risk to zero convert after some time. So this reduces their options in terms of accessing treatment and whether they may use TDF later in life when they are HIV positive. There is importance of engaging key population, and these especially sex workers, women who use drugs, transgender women in decision-making processes in terms of implementing PrEP. There is a big push towards accessing PrEP, making it accessible to sex workers for example, in the 10 dream countries. But where are the sex workers in these discussions? Do they actually really need PrEP? So those are some of the discussions we really want to have. Other gaps are, we know that, and I talked about it, the biological difference in men and women. For example, we've been talking about where is the data to show the effect of long-term use of ART by women living with HIV. And the same question will be asked for PrEP. And what data do we have? What information do we have for the effect, the long-term effect that this will bring to women if they use prolonged use of PrEP? We talked about the side effects, and one of the things that we've seen is the fact that even in the Gilead website, and they talk about Truvada, it is clear that it has mentioned that PrEP or Truvada is not safe for women who are pregnant, and so it is important to ask ourselves these questions: the side effects of Truvada and the baby. I know Lynn has mentioned about it clearly. What are the kind of messages we are sending out to the community? PrEP is very key for 0 different couples, and it should be championed as an option, not the only option. So we want to give 0 different couples an opportunity to make that decision, offer options for them to access various HIV prevention strategies and information about conception and breastfeeding and keeping the child safe. So when we go forward to some of the concerns also that were raised, it's that Truvada PrEP trials have not included pregnant women who are HIV negative. And so, as I said, and it was mentioned earlier, there is no knowledge of and on effect of the unborn child. Also, the ethics of doing trials on pregnant women was clearly raised, and the issue of possible resistance in the future. Let us invest on structural interventions. We cannot medicalize everything because there are some people who will not access PrEP. There are some people who will not be comfortable in taking a pill every day. So what about the other structural interventions? We've been talking about the condom use. We've been talking about other HIV prevention, information, education, empowering young women and making sure that they are in leadership position. And all these, we know that they are interventions that really work. So why can we go back and see, in addition to PrEP, what other interventions can we invest in to ensure that our children stay HIV negative? So I want to stop there and let Angelina also continue with the other slide on concerns.
Okay. Thank you very much, Teresia. I'm just trying to work this now. Okay, so thank you, Teresa. I think you've kind of gone through all the concerns that were raised during the consultation, and I'm actually going to move on to the opportunities and recommendations. Okay, so what the community felt was that it's important in terms of also getting people to work around condom negotiation training, and also for couples as part of our greater GBV reduction programs, and then introducing PrEP as well. Teresa also has mentioned it's important that, sex workers and women who use drugs, for instance, consider motherhood too, and should be meaningfully involved. And then we have to be really careful about making sure that it's actually involvement rather than being coerced in the decision-making process around accessing and using PrEP. One of the things that the community felt was that actually we agree PrEP could be useful psychologically too. Couples could have better sex because they know they're using this protection, peace of mind. But of course, although we know that in some couples, it may not be like a decision of both out of choice. However, if both couples wanted it, then it could things could work out even better. But as already mentioned before by the previous presenters, we do need more data and focus on the involvement of adolescents and young women. This is really, really key. And I just want to share a couple of quotes from a young person who was reporting from the Durban conference around why it is incredibly important to involve adolescents and young people in these discussions. I'm going to let you read the two quotes for yourselves. Okay. So just continue with the opportunities, because of course as a community, we don't always just talk about concerns. We also talk about opportunities and where these things could work even better. I think Heather mentioned already before about the several different couples face complicated choices between balancing fertility intentions versus the risk of transmission to a partner and a baby. And for those of you who might be wondering why we use the term serodifferent as opposed to serodiscordant, is because for us as a community, this is the preferred term, because discordant kind of has negative connotations, whereas the thing here really is just this couple out of different HIV statuses. And of course, we mustn't forget the fact that using PrEP is a great opportunity to prevent vertical transmission. And one of the other opportunities is that, and again, Teresa slightly mentioned this, we really feel that PrEP should be incorporated alongside screening and treatment of STIs and broader provision of SHRH. But it's really also important. I mean, we can have this fantastic science available and a tool available to us. However, we do need to improve healthcare systems in terms of accessibility, affordability, and quality training for healthcare providers. Just as much as we want to give the information to the community, we also need to be skilling up healthcare providers to be able to actually offer this PrEP in the right way and in the sympathetic way. Okay, so just moving on. Of course, we mustn't forget that women living with HIV do have several different partners. And here, just wanted to share this picture of a couple of women living with HIV who are advocating for PrEP. One of the key things that continually comes up is that community are continuously calling for the translation of science into wider awareness, into our community education. The thing is, some of us women who are on the webinar today are very lucky because we're able to access the scientific information, we're able to ask the questions, but many of the community of women who are actually going to be using PrEP don't have access to these structures and to these forums. So we actually need to be, very careful in terms of how we put the messages across. And that way, when community get the information in the language that they understand, it's actually much more easier for them to actually make informed choices, not just around PrEP, but also about preconception advice. So moving on, I just want, before I finish our presentation, I just wanted to just thank a few people without whom our presentation wouldn't have been possible. So Aditi Sharma from GMP Plus, the Athena Network, the Global Network of Sex Workers Project, Alice Welburn from the Salamander Trust, of course, the International Community of Women Living with HIV, and Simon Collins from HIV-IBES. And I'd just like to finish our presentation by sharing this clip from Winnie Sanyu Seruma, who is advocating on BBC World Have Your Say, advocating for PrEP. Heather, would you be able to play this for me, please?
Let me see if I can do this.
I'm just preparing the video. Hold on 1 second.
I think it's loading now. Really?
Yeah.
Are you able to see the video?
Yes.
I think it's still loading.
Okay, I'll play it when when people can confirm that they can see the video.
It's loaded.
It's here.
Okay, great.
Oh.
All right, Heather, I think we could start, maybe open the floor for questions, comments.
Oh, I first want to thank all of the presenters, and again thank Nellie for providing the slides, and I'm very disappointed she wasn't able to be on, but I appreciate her efforts, and I want to thank Lynn, Teresia, and Angelina. So at this point we'll open it for questions. Do people unmute themselves and ask, or do they type in questions? Are we still online?
Yeah, I have a question.
Okay.
Okay, so Heather, it's going to go to you, and it's something you mentioned which I'm quite interested in terms of you mentioned the fact that clearly it was the issue around whether the PrEP was effective in the trials was around adherence. My question is, has there been any qualitative studies done with the women in terms of looking at why they found it difficult to adhere?
Yes, I know, for instance, so the question is, what information do we have on why the women found it difficult to adhere? And I know, for instance, in the VOICE trial that they're doing some very extensive work going back. Well, they added in toward the end of the study, and then also now looking at issues. And I think there are a whole host of reasons. I think there were probably some women who enrolled into the trial to begin with more for the benefits of the care and some of the remunerations, perhaps, and were less interested in the HIV prevention aspects. But I think also there were issues of obviously not knowing if they were on active drug or not, so having maybe less incentive. I think there are a lot of issues with the fact that in many cases, the study drug looks the same, the Truvada looks the same as treatment, and so there were issues of people not wanting to be carrying pills around, that people might think that they were living with HIV or just not wanting to carry pills around. Various levels of partner engagement in the process. So I think there are a wide range of reasons, and obviously those need to be explored because some of those will continue to impact adherence if women are on open label or, using it in the real world. And I know that one of the things that we're trying to look at from a PEPFAR perspective is working to see if there's alternate packaging, alternate like making a white pill versus a blue pill, whatever, even co-packaging with contraceptives and things like that, to try to make these drugs more acceptable for women to actually be having them and using them. But I think it's multifactorial.
Thank you.
Okay. Here's a question asking, why would the preference be for positive women to be started on PrEP when we have moved to test and start? Is there research to show that PrEP is more effective than ART? What about the cost and health benefits for short-term versus long-term interventions for HIV-positive women starting on PrEP instead of ART? So I think that but Lynn can comment on this as well. I mean, I think, again, this issue for serodifferent couples is if you identify a couple that are serodifferent, say the man's infected, that you would want to get them onto treatment as soon as possible for their own health and to decrease the risk of transmission. But there's going to be a several-month period while they're initiating treatment, while they may have detectable viral load and still be at risk of transmission, so that the PrEP could be sort of the immediate protective for the woman while the partner is getting on treatment. There are sometimes, for various reasons, access at this point or preference that the men may not choose to start treatment, and again, the PrEP would offer a benefit to the woman. But we agree that one of the goals is to try to provide treatment for those living with HIV to get to the 90-99 and get to undetectable and reduce the risk of transmission, which would then hopefully obviate the need for the PrEP.
Yeah, I agree, Heather. That would be what I would respond to.
Okay, so there's a question that says, women in urban South Africa did not even know about ART for prevention, much less pre-exposure prophylaxis. What are the solutions to this? And obviously, lots more information needs to be getting out there about number one, the benefits of knowing your HIV status. Number two, the benefits if you're infected to getting on treatment early for maintaining health and decreasing risk of transmission, and all the options for prevention, including condom use, pre-exposure prophylaxis as appropriate, and medical male circumcision, all of that. So obviously we need to do a better job with education everywhere. The questions are disappearing up my screen here. Okay. Another question is, are there plans for education for women about PrEP? In my experience as a community member, there's no information. And I agree that there's a lot more that we need to do with information. Maybe Teresia and Angelina could comment on what their groups are doing as far as education about PrEP.
We haven't done an extensive amount. However, we do hear the call from the community quite a lot, and only, I think last year, and they will do it all the time through the what you call the HIV I-based website. A couple of things we do. Firstly, last year we did a treatment, I would call it treatment literacy workshop with women. And then what we do is we incorporate, treatment information, literacy, but also stuff around PrEP. We also have a community-based network for in the UK. I'm based in the UK. It's made up of about quite a few hundred community-based organizations and people living with HIV. So that is a forum whereby we update people on the knowledge around treatment and around research, around PrEP. There's also, online forums that we use. Also, the HIV-I-Base produce, although they do an online Q&A, but they also produce booklets and leaflets and online information in language that the community can understand. So this is available to anybody who signs up, or they can literally just go into the website and type in a question. So we try and provide information in different ways, but this obviously, as you can appreciate, doesn't always reach the community who need it.
Great. Yeah, and I think, another question is, does PEPFAR have plans for treatment literacy communication in countries with policies in place to implement PrEP? And absolutely, obviously through DREAMS, we're trying to facilitate availability and information on PrEP in those countries that have it as policy, and trying to expand where that will be. Through the Innovation Challenge Fund, several projects are slated for potential funding that are looking at trying to increase information on PrEP for the community and provide, for instance, peer educators and sort of community leader training for young women to make them the knowledge point to then educate additional women and sort of have the multiplying effect. So and I think one of the key things will be for all of us, all of our groups, to try to coordinate as we develop things, as we evaluate ways of providing information, to share those and make them widely available so that people aren't having to reinvent the wheel in different places. One of the questions is, given that 22 million people still need ART, what is the balance between ART and pre-exposure prophylaxis? And, obviously that's a consideration everywhere, and obviously the balance between how much should go to prevention to prevent more people needing treatment versus treatment to prevent transmission and maintain health. And I think, obviously, one of the things we need to do is to continue to mobilize more resources, both donor resources and domestic resources in countries, for them to respond to the epidemic, and also, to step up with more treatment availability, but also prevention. And each country in each setting is going to have to figure out their balance between treatment and prevention. The next question, the presentation compares clinical outcomes to different drug regimens with each other, but does not compare these outcomes with those occurring in the general HIV negative population. I think we need this type of evaluation to evaluate the net benefits of providing PrEP to HIV negative pregnant women. Is any information of this kind already available, or do any of the studies presented include this type of information? If so, for what clinical indicators? Lynn, I think I'll turn that one over to you.
Yeah, so I think there's this is even a little bit more shaded, which is that the HIV at risk population may actually be different than the general HIV-uninfected population. They may have different risk factors for things like preterm delivery, et cetera. So it's actually a little difficult to get this information. None of the studies compared to a HIV-uninfected population in general. But if you think back to some of the slides that I showed, the rates of adverse pregnancy outcome in the hepatitis B virus-infected women were really low. And I don't think that if you compare those to the general population that they would be very different, because they were in the rates of 0 to 3%. So I think that while I don't have the data to provide to you, I think if you look to the uninfected population, the hepatitis B monoinfected population, that I don't think that it's an elevation above and beyond that in non-pregnant women. Now, that's said without having the data to back that up, but take a look at the slides and look at the numbers. And then the other question about stopping PrEP if the woman becomes pregnant, et cetera. I think that WHO is struggling to be more clear on this. I think the drug company label implies that for pregnancy it says only use if the benefit outweighs the risk, and for breastfeeding it says don't breastfeed, but that's really a label for populations in resource-rich countries. So WHO is struggling to pull together the data to be able to say, no, you shouldn't stop PrEP if you get pregnant, and no, you shouldn't stop PrEP if you're breastfeeding, and that's one of the reasons why they asked me to do that review. So I think once we have a more general policy statement on that, then people won't say that anymore.
Another question is the approach to train peer educators to only talk about PrEP or to educate women about the options, including access to ART? And I think the approach is always to do a broad prevention approach. So it's to educate women about all options, condom use, which obviously they're not always or usually in control of, but safer sex practices in general, condom use, partner testing, VMMC for men who aren't circumcised, who are negative, and then treatment for partners, or obviously if women are tested and are positive, offering treatment for them. So again, I think that we have to always remember that PrEP should be part of a broader discussion of all options, and obviously part of trying to empower women to have choices and control over their own health and bodies. Another question is, a challenge in utilization of PrEP is the knowledge and capacity of healthcare providers. How informed and comfortable are healthcare providers about PrEP in sub-Saharan Africa? And I think that's an area, obviously, where we still have a lot of work to do. I think as, you know, the guidelines, the WHO guidelines sort of being permissive for PrEP in the more general population, their initial guidelines were specific to men who have sex with men. Now the broader PrEP guidelines, I think we have a lot of work to do, but I think you know, we can look at our example of sort of integrating PMT-CT into the antenatal setting and being able to provide treatment to women living with HIV when they're pregnant in these settings, that we should be able to build on that, not only obviously in the ANC setting, but try to build on family planning and other settings to educate providers to be able to offer PrEP. And there have been, you know, there were the studies, then there were demonstration projects, and now we're working to try to expand that to broader availability of PrEP. But I agree that we have a long way to go, and you know, many different groups are working on this. The question is, what is the uptake of the WHO guidelines on pre-exposure prophylaxis within HIV national strategic plans, particularly within countries implementing DREAMS? Kenya and South Africa have both approved PrEP in general. I think, you know, that's the first step. And the issue of pregnant women remains to be worked out. In countries, I think we also just need to work on increasing PrEP in the national plans of other countries as well, and that work is ongoing. But again, pregnant women, I think, are a group that's still under discussion. For instance, in South Africa, they're not currently recommending PrEP for pregnant women, but that's an issue that's trying to be addressed on a broader scale, and also by WHO with things like Lynn's review. They're currently permissive guidelines, but ongoing meetings to look more in depth and see if there needs to be more specific guidance issued to facilitate uptake in broader areas.
I think we have a comment, Heather.
Yeah, I'm just reading through this. It says, I think healthcare professionals have a vital role to play, especially for people who may not have access to information from other sources. However, they tend to attend clinic appointments, and that is an opportunity for education. It brings the point about peer mentors in clinics. Sorry, somebody just asked longer question. It will be useful for science to also emphasize the importance of other forms of support together with medicine that makes a difference to the patient to promote the provision of wholesome care that complements medicine. Yeah, I totally agree. Obviously, and you know, from a PEPFAR perspective, when we're trying to look at HIV prevention in young women, we're trying to look at obviously not just PrEP and not even just sort of clinic-based interventions, but try to look at gender-based violence prevention and gender education for both women and men to improve opportunities for women, keep girls in school, improve education, you know, a multifaceted approach so that, again, this webinar was focused on a very, very small subset of the whole issue of PrEP and pregnancy, but I agree that this needs to be part of a broader package. Let's see, we've got a really long question here.
So this is Lynn. I can try to answer some of it. So the question was about girls 14 to 24 being at the highest risk and they might get pregnant and the group who could most benefit, but there's concerns about bone mineral density in this young group. So yes, I think there are concerns about bone mineral density, but if you think back to the studies of MSM, and the bone mineral density studies there, they show a mild decrease in bone mineral density that stabilizes while people are receiving PrEP. And when you stop it, the bone mineral density goes back up. And the Adolescent Trials Network in the US did studies in adolescent men who have sex with men. So these are youth between 15 and 24, finding basically the same thing, that there's a decrease in bone mineral density, that when you stop the PrEP, it goes back up. So I think that, and once again, the issue of risk versus benefit comes in. So if you have a mild decrease in bone mineral density that goes back up when you stop, is that risk enough to be able to deny to a woman who's at high risk of HIV the availability of a potentially highly effective intervention? And I think that's the way I would try to think about this. When you're giving a drug, there's never no risk, but it's the question of, is the benefit outweighing the risk? The other question had to do with adherence, and I think, you know, you clearly need to put in place measures to be able to help people adhere, and that is whether they're young or they're older. Adherence is the key. And while I agree that adolescents have somewhat more problems with adherence than older people, I again don't think that that's a reason to deny someone, particularly someone motivated to use the drug. And in the ATN studies, the individuals who engaged in the highest risk behaviors were the people who were most adherent to the PrEP. So I think people will be different. You need to help them, but that's not a reason to say that people can't be able to access it.
That's great. I think one clarification that I should make, given my position, is that at this point, PEPFAR is reviewing the data. The Scientific Advisory Board and the PrEP External Working Group of the Scientific Advisory Board is reviewing the data and should be providing recommendations to PEPFAR and OGAC by early this fall. So I just want to clarify that we're not currently recommending that everybody should be offering PrEP to pregnant women in their PEPFAR programs, but we're evaluating this. And I want to say that Rachel and Giannis are online from WHO, and they're having a consultation at the end of September in Durban with a group of experts to address further these questions. WHO currently does not consider PrEP should be stopped during pregnancy and breastfeeding if substantial HIV risk persists. And following Dr. Moffinson's review and discussion with key experts, WHO will be producing a policy brief that will provide clarity on the use and safety of oral TDF-containing PrEP in pregnancy and breastfeeding women. So I think that this will be a very great help and will help us move the field along. Also, our Scientific Advisory Board recommendations to PEPFAR hopefully will be positive, and we'll be able to do this as well. And at this point, I think we're at the end of our time. I appreciate everyone's participation. Again, want to thank Nellie, who put a lot of time into the slides but wasn't able to join, to Lynn, to Teresia, and Angelina. And I am thrilled with the interest that this has generated, and please stay tuned for more from WHO that will help us move the field along. Thanks, everyone.
Bye-bye.
Bye.
Bye.